So we have been talking about bloodstream infections and all that, and this is just a continuation of this. So enteric fever is an infection which is caused by a bacteria. Okay, the bacteria which causes enteric fever, that is Salmonella, it causes many other diseases. Okay, but this class has been focused mainly on enteric fever. So I just would like you to have a look at this slide. Okay, so today the class is on enteric fever, but for your information, because nowadays we are teaching you the disease, then the bacteria later. I don't know if anyone has mentioned to you, but there's a group of bacteria belonging, okay, there are many bacteria belonging to a group called Enterobacteriaceae. Okay, they all clubbed together in this group because they have certain common characteristics. Out of these, okay, right now we will be concentrating mainly on Salmonella. Okay, Salmonella is a bacteria which has many species. Three species of the bacteria like Salmonella typhi and Salmonella paratyphi are responsible for enteric fever. Okay, so please understand that Salmonella as such as a bacteria can cause many infections, but the ones which are implicated in enteric fever is Salmonella typhi, okay, and Salmonella paratyphi, 3 types, A, B and C. Together they can cause, okay, either we have a mixed infection sometimes, or we have a infection due only to Salmonella typhi. Okay, together they cause a disease called enteric fever. If you see your older textbooks, okay, you might see that these are almost same. Typhoid fever, it means the same as enteric fever. Okay, but then classically we would define that typhoid fever is caused by Salmonella typhi and paratyphoid fever is caused by Salmonella paratyphi A, B and C. But nowadays the concept of paratyphoid and typhoid is it's a very old term. We talk about these infections as enteric fever. Now the other species of Salmonella, apart from typhi and paratyphi, they also cause human infections. Okay. Some of them, these are together called non-typhoidal salmonellosis. Okay, we have a group called typhoidal salmonellosis, that is Salmonella typhi and paratyphi. Then we have another group called non-typhoidal salmonellosis. Why I'm telling you this? Because sometimes you may get a question or you may be asked, what is non-typhoidal salmonellosis? Okay. Remember that they do not cause enteric fever. So these other group, non-typhoidal salmonellosis, they can either cause gastroenteritis or sepsis, especially in the immunocompromised population. Okay, so this chart is only to tell you that Salmonella as a bacteria is it is a large group with many species, many subtypes, serotypes. Okay, but as of today, we will be dealing only on very few of them. So what is this enteric fever? Okay, enteric fever, if you have to define enteric fever, it is basically salmonellosis which is caused by species most closely and constantly linked to human host. And they classically produce invasive diseases. These Salmonella which I have mentioned to you, they are pathogens not only for human beings but also for animals. Okay, most of them cause zoonotic diseases. But the Salmonella which causes enteric fever are closely and constantly linked to human host. Unlike the non-typhoidal salmonellosis, the typhoidal salmonellosis are the ones which are causing human infection. Okay, they are causing human infection and they produce invasive disease. Okay, it's a very common disease. Unfortunately, even today we have lots of cases of enteric fever. So enteric fever, okay, it's an invasive disease. It is caused by species of Salmonella which are closely associated with humans, that is mainly Salmonella typhi and Salmonella paratyphi A, B and C. So this infection is basically a generalized infection of the reticuloendothelial system, okay, and the intestinal lymphoid tissue, which is accompanied by fever and bacteremia. So the patient usually presents mainly with high fever, okay, but it is an infection which affects the reticuloendothelial system as well as the intestinal lymphoid tissue. The patient usually presents with fever and bacteremia. That means the presence of bacteria in the blood, okay. Of course, there may be other symptoms, mild symptoms. They may present very vague symptoms are there. They might present with diarrhea, they might present with headache, some of them with constipation. But generally, these are the systems which are affected and patient presents usually with fever. So like you all know, like I have mentioned before, okay, typhoidal fever is the one which is more severe compared to paratyphoid fever. Both are together clubbed and called enteric fever. The one which causes typhoid fever and the one which is more severe is Salmonella typhi. Okay, paratyphoid fever is confined to small areas, to small regions, okay, and it is less severe. Paratyphi A and B is commonly isolated as well as reported in India, okay. Salmonella paratyphi C, Okay, these are the new names. You don't get confused with them. Paratyphi C is the least severe of all the three, and we hardly, patients hardly come to the hospital because it is self-limiting. Okay, but we do get cases of Salmonella typhi, Paratyphi A and B causing enteric fever. Okay, coming to the organism as such. Okay, this Salmonella is basically a gram-negative organism. Okay, so when you stain it, you will see it as gram-negative bacilli. Okay, so if you get the patient sample, mainly the blood is collected in this situation. We try to stain or we grow it artificially in the laboratory. We will get a gram-negative organism. Okay, it is a bacilli. It is a straight rod. Okay, it is motile. It's got flagella, so it's motile. Okay, and it is a facultative anaerobe. Okay, it can ferment glucose, and this is very, very important. It is an intracellular pathogen. Okay, it will multiply within the cells. Okay, so you must remember these common characteristics. It is a gram-negative bacilli, which is motile. Okay, and it is a intracellular pathogen. It cannot survive outside the cell. It has to multiply within the cell. Now, just for your information, it's important to know the classification of Salmonella because sometimes you're often asked. Initially, in the old nomenclature, okay, we used to classify Salmonella based on serotypes or biochemical tests. Okay, and we would name them based on the serotype or biochemical tests. We would have different names for them. Okay, and the famous serotyping that we do is called the Kaufman-White antigenic scheme. So, okay, in this scheme, there are more than 2,400 serotypes which are referred as species. Okay, so sometimes you may be asked, how to classify Salmonella. How do you classify them? So this is an old scheme where we have so many serotypes of species based on the O and the H antigen which is possessed by the bacteria. Okay, or we can use biochemicals, okay, that is called bioserotyping, and then accordingly name them. Today, because of the advancement in the in science, okay, we have technology where we do direct DNA homology, okay, and this DNA fingerprinting, and we have found that Salmonella basically contains only of two species, okay, one is Salmonella enterica species and Salmonella bongori. Okay, now the human pathogens, all of them belong to one of the species, one of the subspecies here, and that is a Salmonella enterica subspecies enterica. So when we talk about enteric fever, okay, it belongs to this subspecies of Salmonella enterica, that is enterica subspecies enterica. Okay, this is just for your information because Kaufman-White scheme, though very popular, it is now old classification. Now, if anyone will ask, or if for your information, remember that there are only two species that has been divided. One is Salmonella enterica and Salmonella bongori. You can forget about bongori because these are infections which are present in animals. Whereas in this Salmonella enterica, it is further subdivided into subspecies, 6 subspecies, and one of them, Salmonella enterica subspecies enterica, is the one which contains most of the human pathogens. Okay. Now, you may ask me why I am teaching you the antigenic structure. It is very, very important to know about these antigens which are there in the Salmonella before you know you'll definitely know about the disease also, because there are some serological tests that you will use for diagnosis of Salmonella, that is enteric fever, based on the presence or absence of antibodies against these antigens. Okay, please understand. Finally, you will study the disease, but you will have to confirm that it is enteric fever. So you will there are many methods, okay, but one of the methods is to use serodiagnosis. In serodiagnosis, you will basically look for antibodies against the antigens of the bacteria. Okay, so one is O antigen. O antigen is present in the Salmonella. It is a O-specific polysaccharide, okay, located in the lipopolysaccharide region, LPS. Okay, and remember that a single Salmonella or a single organism may carry several O antigens. Okay, this is the O or the somatic antigen which we call. This is the H antigen or the flagella antigen. This is heat labile, unlike that which is heat stable. Okay, and this is always present. The O antigen is always present, but this H antigen may be absent or undergo phase variation. So it has two phases. Okay, based on some certain mechanisms, it can switch the phases. And then, of course, apart from the O and H antigen, we also have a capsular antigen which is called the VI antigen, and it is exterior to the or external to the O antigens. Okay, it may or may not be present. Okay, now if you look, this is the structure of the organism. Okay, this is the flagellar antigen or the H antigen. Okay, then you have the capsule antigen. This is a capsule antigen. Okay, then you have the lipopolysaccharide. This is a lipopolysaccharide. Okay, so in the lipopolysaccharide you will have this O antigen. Okay, this is the O antigen. Okay, this is a polysaccharide core antigen, and this is a lipid. These are all here in the cell wall. Okay, so this is just to show you. No one will ask you about this, but you must understand that these are the main antigens which are important for the pathogenesis also, as well as for the diagnosis later. So how do you get enteric fever? This infection is transmitted orofecally. Okay, so you will get enteric fever only by ingesting of contaminated food or water which contains Salmonella typhi or paratyphi. Okay, and please remember, the infective dose is important. Okay, the infective dose for Salmonella will be very high. It's around 10 to the power 6 or 10 to the power 8. Okay, unless that particular food is contaminated with that much number of organisms, you will not get the infection. Okay, so the infective dose is important. The route of infection is very important. Here it is a orofecal route transmission. So the infection will get only if you ingest contaminated food or water. Okay, so the food or water which is contaminated with these organisms will pass to the mucosa of the intestine. Okay, there it will cause membrane ruffling. Okay, and will releases certain proteins. Okay, and these organisms will get engulfed by endocytosis. Now, what is important is, what makes a Salmonella so infectious or so virulent? Okay, so it is mainly because these bacteria can invade cells. Okay, they can cause cell-to-cell infection. By virtue of being a gram-negative bacteria, they contain the lipopolysaccharide, which is known virulent factor for all gram-negative organisms. Okay, which includes Salmonella. They can multiply intracellularly, evade immune mechanisms. Okay, and though not well defined, maybe they do elaborate toxins also. Okay, so these are the factors that are responsible. Okay, that are responsible for the pathogenesis or the virulence of these organisms. Okay, in addition to the factors which are there in the bacteria, okay, there are certain conditions which will promote, because you will find that some people are more susceptible to these infections and some people are having they have a tendency not to have the infection. These certain conditions which are there in the person might predispose them or might make them more susceptible to salmonellosis. Okay, a person who has undergone a gastric surgery or a person having achlorhydria. Okay, individuals who are on high-dose antibiotic, or who has undergone GI surgery, or have irritable idiopathic inflammatory bowel syndrome, these people have more tendency to be susceptible to enteric fever in particular, or any salmonella infection in particular, because of certain here the acidity. See, for people with achlorhydria or gastric surgery, what happens is the pH in the stomach is reduced, the acidity is reduced. Then we have certain people with hemolytic anemias, especially sickle cell anemia and other hemoglobinopathies. They are also susceptible to Salmonella. Then other cases like carcinoma, leukemia, lymphomas. Okay, these are all other immunosuppressive states like AIDS and all. They are all susceptible to more susceptible to Salmonella infections. Okay, which includes enteric fever and other infections caused by the non-typhoidal Salmonella. Okay. So you must understand that Salmonella typhi and paratyphi, they are primarily infective for humans. Okay. The other species of Salmonella are pathogenic in animals, like poultry, pigs, rodents and all. And they constitute the reservoir for human infection. Like for the example, the non-typhoidal salmonellosis, mainly they cause enteric fever-like picture in the rodents. Okay, but it can spill over and cause human infection where it can present with GI symptoms or sepsis. The infective dose for Salmonella infection, like I had mentioned to you, it's around 10 to the power 6 to 10 to the power 8 colony forming units, per ml. So it is very high dose. Okay, you must remember this, because later when you are taught about another infection like Shigella which causes dysentery, there the infective dose is very less. So even if a person is exposed to a very small dosage, he will end up with the infection and like dysentery in Shigella. But here, here it is, the infective dose is very high. Okay, in children, infections can result direct from fecal-oral spread. Okay, not necessarily from not necessarily from a contaminated food or water, directly from fecal-oral spread. Sometimes they can easily get it. The common sources of human infections are poultry, eggs, dairy products, and foods prepared on contaminated work surfaces. Okay, the major source of infection, you must understand that the major source of infection for enteric fever is the carriers. That means once a person has suffered from enteric fever, usually the disease, when it's treated or sometimes it's self-limiting, the bacteria will disappear from the system of that person. But some individuals have the tendency to keep shedding this bacteria in the stool sample. They become carriers. Okay, there are different types of carriers. So they will be the source of continuation of the disease. Okay, I'm going to repeat. Normally, if the disease is occurring in an individual, that person will clear off the disease or the infection after the treatment is over, or sometimes the disease may be very mild and it is self-limiting. Okay, he will not continue to shed the bacteria in the stool. But in some individuals, they will continue to shed the bacteria for a long time in the stool sample and they will become carriers. That means they themselves will not suffer. Okay, they will not have any symptoms or signs of this enteric fever, but they will continue to shed the bacteria in the stool sample. Okay, and if that stool sample gets access to any water or any food, or any food handler, the person who has suffered from enteric fever is a food handler, he will continue to pass on the infection. So the major source of infection in human beings for enteric fever is usually a carrier. Okay, and for this reason, it is very important to even in healthy individuals who are in close contact with preparing, like for example, preparing food in the hostel or in the hospital. I'm just saying, because if those people are carriers, and if they're not very hygienic, what will happen is they will contaminate the work surface, they'll contaminate the food. So they will continue to serve as a source of infection for many people. Okay, this carriers they are called. These people do not suffer, so they are asymptomatic. Okay, chronic carrier can occur in 1 to 5% of cases following Salmonella typhi or Salmonella paratyphi infection. So out of 100 people who are affected with enteric fever, 1 to 5% may become chronic carriers. Okay, and this bacteria will continue to multiply and in the gallbladder. Okay, so the gallbladder becomes a reservoir. Chronic carriage with other Salmonella species occurs in less than 1%. In other Salmonella species means those Salmonella which we refer to as non-typhoidal Salmonella, which causes gastroenteritis or sepsis, they will not have the carrier state. Even if it's there, it is very mild, it is less than 1%. And it does not play a role in human transmission. But in enteric fever, it is the carriers who are responsible for human infection because they keep shedding the bacteria in their feces. And if they are not hygienic or they are involved in, in the preparation of food or, those in the kitchen, they will be constantly giving out spreading out the infection. Okay, we have a person by the name of, and this is very famous, Mary Malone. Okay, she was a chef and she was responsible for infecting so many people. Okay, she was a carrier, she had suffered because enteric fever was nowadays, of course, it's there only in India. In most of the developed countries, they do not have because, the hygiene level is very good. So she was responsible for infecting so many people because she was a food handler. Okay, so this is a very famous example in the history of enteric fever where a carrier was able to spread the disease to so many infections because she was directly handling the food and was responsible for preparing food for so many people. Okay, now coming to the clinical progression and the virulence invasiveness of the disease. Okay, Salmonella typhi is ingested. The route of infection is orophycal, you all know. Okay, as a person ingests the Salmonella typhi, the typhi will pass, the bacteria will pass through and between the epithelial cells lining the ileocecal area. Okay, there within the intraluminal space, it will multiply. Okay, and here is where the immune cells will react. Mononuclear cell response will be here. Okay, If the organisms remain viable after engulfment by the macrophage, okay, they will get engulfed by the macrophages, and if the immune response is adequate, they will be killed. But if they remain viable after engulfment by macrophage, there will be intracellular multiplication within the cell of the reticuloendothelial system, that is within the liver, spleen and the bone marrow. Okay, it is at this phase when there is multiplication within the reticuloendothelial system that the person will present with clinical signs of sepsis, fever, bacteremia and so on. Within the cell there will be, within the reticuloendothelial cell there will be hyperplastic changes in the mesenteric lymphoid tissue, which may end up in necrosis or hemorrhage and perforation of the intestinal wall. So a severe enteric fever presentation may end up even with hemorrhage or perforation in the intestinal wall. After this changes, the bacteria will re-enter the bowel, and then to the liver, to the gallbladder, to the intestine, and it will shed also in the stools. At this phase, it will even shed into the stool specimens, a stool sample, and the patient may present with GI symptoms like loose diarrhea, loose watery stools or diarrhea. So this is how it causes the infection. So after a person ingests the salmonella in the food, provided that the infective dose is adequate, it is only after 7 to 14 days, that the person will start presenting with symptoms. So the incubation period would last from 7 to 14 days. In the first week, the patient will present with high fever, headache, malaise, bronchitis, dry cough, malaise, weakness, headache may be there. These are non-specific. In the second week, the patient will present with anorexia, apathy, confusion, stupor. This is, where a case of a severe enteric fever kind of presentation. In the third week, you may see rashes. You may, especially in a fair skinned person, you may appreciate rashes on the skin, rose spots they are called. There may be abdominal tenderness, where the liver, the spleen may be enlarged. There will be on palpation there may be abdominal tenderness. There will be pain. Patient may present with loose watery stools. There may be, and because of the spleen and the liver may also be enlarged because of the multiplication of these bacteria within these endothelial, within the reticuloendothelial cells in the liver and the spleen. These may be there. Delirium and mental confusion may be there. And long-term effects means, long-term sequelae, patient may present with arthritis, and further many more complications. But this is usually the picture. So in the first phase, sometimes it is very difficult to pinpoint that it is a case of enteric fever because these are very non-specific. Fever can be there in any other infectious disease. Headache is also non-specific, malaise and bronchitis. So it is very difficult because it is only that's why sometimes it is important to have a laboratory diagnosis to be able to treat them and to recognize them, because initial phase of the disease or even towards this side, towards the second week, the presentation is not very classical. Now, based on this, you must understand that it is important to diagnose the enteric fever. One is because we can treat it, there are specific antibiotics for treatment of enteric fever. It is very, very important. And you can diagnose enteric fever by many methods. You can grow the bacteria if the bacteria is present there in the blood, because this disease can cause multiplication of the bacteria. You can diagnose it by culture. You can collect the sample from the patient and try to grow the bacteria artificially. You can also diagnose enteric fever by serological tests, where you look for antibodies which have been mounted against the infection, that is antibodies to O antigen or antibodies to H antigen. Nowadays you can even go for molecular tests. You go for a PCR where you look for the specific DNA of the Salmonella typhi or paratyphi. There are many tests which are available. But it is important to know which laboratory test to use at which phase of the disease. Usually in the first week, you will not be able to use a serological test which is looking for antibodies, because antibodies are not manifested, they are not made in the first week. So in the first week, if you want to diagnose enteric fever, you would have to go for something like culture. You either culture one of the commonest samples that we use is a blood. So we can culture the blood and look for the presence of these organisms in the blood. Antibodies would mount or would increase only by the second week. So in the second week, you can go for, if you have taken the history properly and you realize that he's been suffering for a week or so, In the second week, you can go for serological tests where you look for the presence of antibodies to the O or the H antigen. Okay, and this serological test will be present even in the third week. Okay, in the third week, if you look at how the disease progresses, by the end of the third week, the organism may be shed in the urine. Okay, and eventually by the fourth week, the organism will be shed in the stool also. So you can culture the urine, you can culture the stool, but it all depends on which part of the disease, which phase of the disease the person is. Okay, and in the first week, apart from blood, okay, there are some invasive techniques. You can even take the bone marrow and look for the presence of these organisms in the bone marrow. That is, in fact, is one of the best samples, but we don't use it commonly because it is difficult to do a bone marrow aspiration. Okay, it's much more easy to collect blood. Okay, so this is just a gist. Okay, so laboratory diagnosis essentially would consist of isolation. Isolation means you would culture artificially in the laboratory. You would take the concerned sample, whether it's blood, whether it's stool, whether it's urine, okay, whether it is scrapings from the rose rashes, rose spots, okay, it could be the intestinal contents. You would have to isolate. That means you have to grow it. Okay, after you grow it artificially, you will have to use biochemical tests to identify. Okay, this all of you know, but I'm just revising. So you would grow it artificially in a specific media, okay, whether enriched or selective media, whatever it is. Then you would identify the bacteria which has grown. Definitely it will be a gram-negative bacteria which is motile, okay. So you will have to use specific biochemical tests to identify, to prove whether it's Salmonella typhi or it is not Salmonella typhi, okay, or whether Salmonella paratyphi. And you would subject that bacterial growth to antibiotic susceptibility tests. The reason for this is very, very important because there's a lot of resistance that has been reported in Salmonella typhi and paratyphi. So it is, your diagnosis would be incomplete if you do not perform this susceptibility test. Okay, so it's very, very important. Then, of course, like I said, in the second week, you can go for serological diagnosis. There are some things that I have to teach you regarding serological diagnosis, okay, that how to interpret. Then, in general, you can either detect the agent, that is the organism, okay, or you can detect the products, okay, that is the antigens, the antibody, or you can look directly for the DNA. So this is a rough chart which is there everywhere, okay. In the first week, okay, if you culture, the most sensitive sample would be blood. I'm adding to it bone marrow. Bone marrow is still the best, okay. In the first week, the chances of recovering the organism is maximum from the blood, okay. In the second week, okay, you may get, okay, you may get from the blood, you may get from the feces, okay. Then in the third week, okay, the chances of getting from the urine and the feces is more, okay, it's more rather than compared to the blood. And by the time third week, the isolation rate from the blood is very less, okay. So this is how you will decide. So it's very difficult to depend only on one test. Okay, blood culture is usually positive within 7 to 10 days, that is in the first week. Stool is usually positive by the second week, okay, and urine by the third week, okay. And of course, we can collect serum sample and perform the serological tests. Now, if we have to grow these organisms, please understand, if we are culturing or growing the organism from a sterile fluid like blood, we need not use selective media, okay. We can directly use any media because we presume that we know that blood is sterile. So if Salmonella is there, Salmonella will grow, okay. Otherwise, if Salmonella is not there, nothing will grow because blood is sterile. But if we are going to culture stool, please understand, stool sample is very, very contaminated. In case we have to use stool sample for culture, because stool is not sterile like blood, then we have to use selective media like McConkey, okay, DCA or XLD. Okay, you'll be shown these in the practicals. So it all depends. If you are using blood, then we use a blood culture bottle, okay, which contains brain heart infusion broth. It is an enriched broth, okay, and we don't have to use any selective agent because in blood, nothing is there to prevent the growth of Salmonella if it's there, okay. So we use brain heart infusion broth. I have shown you in one of the classes, I think the bottle, I have shown you in one of the classes where how do you collect the blood. That is in the class which I have taught you about bloodstream infections, okay. But if you have to grow from stool sample, then you will have to enrich the stool using enrichment broth to prevent the growth of other organisms which are not required, okay. Then you would have to use, apart from enrichment broth, you have to put the stool sample or the feces in the enrichment broth. Then you would have to use selective media, because you have to suppress the growth of the normal flora which is present in the stool. And of course, it will be the same thing. You identify and you confirm. Okay. So culture, that means growing the organism directly from the samples. You have different samples. You have blood. Like I said, blood is the best sample. Stool will be positive only by the 2nd or 3rd week. So is urine. Rose spots, you can scrape those from the rashes also sometimes. You can get the organism. Okay, you can take the blood and centrifuge it and you culture only the buffy coat. Bone marrow is an excellent sample. In fact, even after starting of antibiotics, you can still isolate or you can still grow the Salmonella typhi from the bone marrow. Okay, sometimes you can collect the bile also or the intestinal contents. Okay, but for your information, routinely only blood is sent for culture. Okay, but if you are suspecting that the patient is in the 2nd or 3rd week, you can send these. And if you have a diagnostic dilemma, your blood sample is not that sensitive, you can always go for a bone marrow aspirate and send that for culture. And this will be positive even after you start antibiotics. Okay, so blood culture is the single most useful procedure. Okay, it's positive in early ambulatory stage till effective treatment. Okay, even in cases of relapse, blood culture is positive. The sensitivity is 50 to 70 organisms, 70%, if the number of organisms in the blood is less than 15 per ml. The sensitivity increases with the number of organisms. Naturally, the sensitivity will increase if the number of organisms is more than 20 per ml. Okay, we can also use clot culture where we do not use any anticoagulants. We allow the blood to clot. Okay, then we take the clotted blood and we break it and put it in a broth. Okay, that is also another way, but it's not very popular now. Bone marrow sensitivity is very high. Okay, unfortunately, it is an invasive procedure, so most of the facilities may not be, able to do it. But especially in pediatric age group, we would encourage, if there's a diagnostic dilemma and we cannot pinpoint that it's enteric fever, but you need to grow the organism, you need to do the antibiotic susceptibility, you can go ahead for a bone marrow culture because the sensitivity is so high, it's almost 90%. And one more advantage of a bone marrow culture is that in spite of treatment, okay, in spite of starting antibiotics, even after 5 days of antibiotics, you will still get a bone marrow culture positive. Okay, because if you remember in the class which I had taught you about bloodstream infections, I said always try to collect blood before the initiation of antibiotic therapy. If you cannot, then before the next dose is initiated, you have to collect the blood then. So you remember that, because antibiotic therapy would decrease the chances of growing the organism from the specific sample. Okay, so you can go for urine culture. Then I've told you about media. Okay, in case you collect the sample, like for example from stool, in case you collect sample from stool or you collect the stool sample, you would have to use selective media. Okay, then coming to serology, there's a famous test which is called the Vidal test. Okay, this laboratory test has been used, okay, from quite some time, but you must understand that this test is useful only if you know how to interpret, okay, and it is also useful only if you send 2 samples. There we have to show a 4-fold rise of titer between the first and the second sample, okay, and otherwise it is useless. So this test is a very common test which we use frequently, but please understand that interpretation of this test is very, very important. For example, if you have a person who is vaccinated against enteric fever, all the titers, whether the antibody to O or to H, will be raised. Okay. So here we are basically looking for antibodies. I mentioned in the beginning of the class that we have specific antigens present. We look for antibodies against H antigen. We look for antibodies against O antigen. The antibodies against H antigen will appear early. They will persist for a longer time. They will appear early in the infection. They will persist for a longer time. They might last even for a year. Okay, they may be cross-reactive, but it's less. Okay, non-specific response may be there. O antibody will appear later compared to H, and it declines slowly. Maybe it can persist for 2 to 3 months. So remember that if a person is not having symptoms and your H antibody and O antibody is raised, doesn't mean that the patient is suffering from active enteric fever, because these antibodies will last for some time. Okay, there's cross-reaction, especially with the O antibodies against other bacteria which is there in the Enterobacteriaceae family. If you remember the second slide, I showed you that Salmonella belongs to Enterobacteriaceae family. There's a lot of common sharing of epitopes and amongst these O antigens in the Enterobacteriaceae family. All of them belong to Enterobacteriaceae, whether it's E. coli with the Proteus. Of course, so there's a lot of cross-reactivity. So if you get reaction only against O, okay, and not against H, you cannot say that it is enteric fever. It could be because of UTI due to Proteus infection or any other infection in the body due to a bacteria belonging to the Enterobacteriaceae family. Okay, now this is what I meant, fourfold rise in diagnostic. Suppose you take a sample today and the titer is, suppose 1:80. It is important to show a fourfold rise after 10 days or so. That means after 10 days or so, you will see a rise of a titer of 1:320. Okay, that is called fourfold rise. That will show that the antibody response has mounted. It is really enteric fever. Okay, if you have only one sample and the titer is just 80, okay, or whatever, 160, you are not very clear whether the patient is having enteric fever, because in these serological tests you have a lot of cross reaction, you have a lot of animalistic response. Okay, then there's a lot of cross reactivity, like I said, with other infections. Like there's more cross reactivity with O antibody compared to H. Okay, then these antibodies last for a longer time. The patient may have had enteric fever 6 months back. Okay, but when you perform this Vidal test, because the antibodies will wane off slowly, you will still get a reactive and a high titer. Okay, and even people who are vaccinated also will have high titers. So when you interpret this test, okay, it's very important that even we from the microbiology department, you can always ask us, how do I interpret this disease? We always have to interpret in the light or in the presence of symptoms. Okay, we cannot just isolately just interpret this disease or this test based on these findings of the titers. Okay. And this test is influenced by many things. Okay, if you do this test very early in the disease or in the first week, even if the patient is having enteric fever, if you do this Vidal test in the first week, it will be showing you very low titers. Okay, it will show that it is negative, not suspicious of enteric fever. If the patient is already on antibiotics, that also will be detrimental to the titer. It means, it will decrease the titer. So you will say that no, he's not having. Okay, you will not get a very good reactivity in fulminant disease. Okay, cerebral antigens are released which may not produce a good antibody response. Okay, and there are some people, okay, who will not show any antibody response. So we will have non-responders also. So these are the problems of this test. Though it is a very good test if interpreted properly, unfortunately we get only one sample for diagnosis of enteric fever by this test. Okay, and then we have other flaws also. Okay, so the method of Vidal test is very important. It will be shown to you on the practicals and you may be asked as such in the exams also. It is a tube agglutination test. Okay, it looks for the presence of antibodies against the O somatic antigen and the H flagellae antigen. Okay, you must be very, very careful when you interpret. This is the ultimate thing, that if there's a fourfold rise in titer between two samples collected at least 10 days apart, then that is significant. Remember that this test is not only specific for enteric fever. You may have other diseases caused by bacteria belonging to Enterobacteriaceae, which may also produce antibodies which will cross-react. People who are vaccinated against Salmonella, enteric fever, may show high titers. Okay, and the last one, healthy population. All of us, especially in a developing country like India, all of us are somehow exposed to enteric fever. Some may have had mild infections, self-limiting. So all of us have, when you do this Vidal test amongst the healthy population, we will have some kind of reaction. Okay, so it's important to know the titer of the healthy population. I wish you were here with me. I could explain to you nicely in the board of the class. All of us, especially in a developing country like India, all of us, when we do the Vidal test, we might have some titers for this. We might have some antibodies. Okay, so when we decide the cutoff for a person who is suffering, we must take above the cutoff titer of the normal healthy population. Okay, so in India, some studies have been conducted, one in North Delhi and one in South. Okay, but again, Meghalaya or Northeast is different. No study so far has been conducted in Northeast. But in Delhi, the cutoff is around 1:160. So anyone who has a titer more than 160 is considered to have enteric fever. Okay, this is for non-typhoidal salmonellosis. I don't know if I have time, but I think I will go ahead. So that was about enteric fever. So when we talk about enteric fever, okay, Most of the time, I'm just telling you in advance, okay, most of the time, as an undergraduate, they would expect you to know the bacteria which causes enteric fever. They would expect you to know how to make a laboratory diagnosis of enteric fever. As you go to medicine and all, they will teach you properly the clinical signs, symptoms, okay. But for you, when you're in microbiology, I'll expect you to know what are the causative organisms of enteric fever, what are the laboratory diagnosis, what are the samples we can do for culture, what is the serological test we can do. Okay. Now, apart from enteric fever, the other non-typhoidal salmonella, that is other than Salmonella typhi and paratyphi, they can also cause infections, okay, mainly gastroenteritis, okay, they present with severe diarrhea or sepsis. Okay, here the incubation period can range. There, remember, it was 7 days to 14 days. Here it can range from 6 hours to 10 days. Okay, duration would be 2 to 7 days. And here also the transmission route is mainly contaminated food and water. But the reservoir here, okay, there mainly it was mainly it was a carrier who could spread the disease. Here there are multiple animal reservoirs, okay, and these reservoirs or animals like rodents and all, they would be having the disease, and okay, we may get infected by, okay, by the poultry or the eggs, okay, even the 80% cases are from the eggs. Then fresh produce and exotic pets can cause, okay, infections. Okay, so if it is a non-typhoidal gastroenteritis, patients will present with the typical symptoms: nausea, headache, vomiting, profuse diarrhea which is non-bloody, okay. Then and this is also important, less than 1% will become carriers, unlike in enteric fever, okay. And stool cultures will remain positive for several weeks after clinical recovery, okay. So here it is the same thing. Salmonella will be ingested, it will be absorbed by the epithelial cells in the terminal portion of the small intestine. Bacteria will penetrate and migrate to the lamina propria layer of the ileocecal junction, okay. They will multiply in the lymphoid follicles, reticuloendothelial hyperplasia will be there, and hypertrophy will be there. Inflammatory response will occur, okay, which will mediate prostaglandins. This will stimulate the cyclic AMP, and active liquid secretion will be there, where the patient will present with loose diarrhea stools. Septicemia can also be caused, it is a rare presentation, but it can also be caused by some species of Salmonella like Colerasius typhi and paratyphi, okay. Symptoms are like sepsis caused by other gram-negative bacteria. 10% of patients may have localized suppurative infections. That means they will have a niche where the infection will spread from here to the blood and cause sepsis, like osteomyelitis or endocarditis, arthritis, etc. Okay, sepsis due to or septicemia due to non-typhoidal salmonella or Salmonella typhi is mainly seen in high-risk group population, that is pediatric group or geriatric age, and especially in immunocompromised patients like AIDS patients. Okay, so these are some of the pictures showing you patient presenting with sepsis due to salmonella. Okay, so patient will present with prolonged states of fever, chills, anorexia, anemia, lesions in other tissues also. Okay, and ultimately the patient may go into septic shock and death. Now this is very, very important. So I'll just conclude with this. Treatment of typhoidal salmonellosis. It is very important, okay. This is the treatment of choice as of today, third generation cephalosporins. You must remember this information is what is very important. We cannot treat Salmonella by first or second generation cephalosporins because this is an intracellular organism. Okay, so first and second generation cephalosporins will not get inside the cell, and this is, as I have told you in the beginning, it causes infection by multiplying within the cell. It is an intracellular organism. So we would have to give third generation cephalosporins or quinolones. Okay, example of a cephalosporin, I don't know if you finish in pharmacology, is ceftriaxone. Quinolones are ofloxacin, ciprofloxacin. Okay, these are some important things. Multi-drug resistant strains of Salmonella typhi. Okay, quinolones are the only effective oral treatment. Okay, those which are resistant to nalidixic acid, which is also a quinolone, must be tested for sensitivity to determine course of treatment. Okay, chronic carriers are usually given 6 weeks of treatment with either oral amoxicillin, ciprofloxacin, or norfloxacin. Okay, once we discover that the person is a chronic carrier, how do we discover? We do surveillance. Okay, for example, I'm just giving you an example. Suppose you have the chef or the cooks in the hospital or in the hostel. We would have to collect the stool samples of these patients and screen them. We have to do routine screening. It can be 6 monthly or once in 3 months. Okay, if anyone is having enteric fever and he is involved in the food preparation, we have to screen them. So if we find that the stool sample of the cook or the chef is containing Salmonella typhi, we will have to treat the patient for 6 weeks. Okay. Sometimes, even surgical intervention may be required. where the gallbladder is the reservoir, like all of you know. So he might have to undergo a cholecystectomy. Okay, because when the gallbladder is infested with the Salmonella typhi, we would have to undergo even that. Okay, now for your information, we have vaccine for Salmonella or enteric fever. Okay, we have inactivated whole vaccine. We have the Ty21A, this is a light attenuated vaccine. And we also have vaccine against the capsular antigen. Okay, these vaccines have been shown, they have shown 70 to 90% effectiveness. Okay, so this sometimes may be asked you, what are the vaccines available for Salmonella or enteric fever? Okay, the next class will be on Rickettsia. Okay, Rickettsia C. Okay, there's a lot of interesting things about Rickettsia, but I can tell you in the beginning of the class, okay, these diseases, though some of them are quite common in India, okay, they all belong to a very large group, very difficult to remember, okay? But there are certain points, specific points that you have to remember. This is just for your interest. Rickettsia is a group of bacteria which causes infections in human beings, okay? And the name Rickettsia is mainly because been named after a person, scientist called Howard Taylor Ricketts, who discovered that Rocky Mountain spotted fever is transmitted by tick. That was way back in 1911, okay? And Rickettsia prowazekii, another bacteria, was named after Roca Lima in honor of von Prowazek. Both this Howard Taylor Ricketts, okay, and Prowazek, both of them died of typhus, which they contracted during their study. Okay, so it's important to know that we know what is Rickettsia today because of the people who have sacrificed their lives to study these diseases. Okay, so in honor of Prowazek and Howard Taylor Ricketts, okay, we must remember that they both died while trying to understand how this disease is transmitted, okay. And eventually, Charles Nicholl identified the role of body lice. So it was, they found that all these diseases, that's why they have been clubbed together, because all of them are transmitted by arthropods, either by a tick, by a lice, okay, by a flea, okay. Then Charles Nicholl identified the role of body louse in the transmission of epidemic typhus. They all have been grouped together because they have certain characteristics. The pathogenesis is also similar for most of these Rickettsian diseases. So that is the reason they have been clubbed together in one big group. Okay? So they are a group of bacteria that are fastidious. Okay, you understand? Fastidious, that means they will not grow on ordinary simple media. They are obligate intracellular pathogens. What do you mean by obligate? That means they are strict intracellular pathogens. They will not grow outside a cell. Okay? They are strict, obligate, the other word for obligate would be strict intracellular pathogens. They have to get inside a cell to multiply. Okay? Compared to the other infections that we have studied just the last class we have studied about enteric fever. Enteric fever was caused by a gram-negative bacilli. That means they could be stained by gram stain and they had a specific shape, they were rod shaped. Now these bacteria which belong in this group Rickettsii, okay, first and foremost they do not have any specific shape, they are pleomorphic, okay, or some of them they may take the shape of a coccobacillus. That means they are neither rod, neither round. Cocco is for a round bacteria, isn't it? And bacillary is for the rod shape. So this there are some unique feature, okay? They are obligate intracellular, they are pleomorphic in nature, okay? And they may take the shape of neither of a cocci or neither of a bacilli, they are coccobacillary in shape. And unlike other bacteria, they do not take the gram stain. So if you have to appreciate these organisms and appreciate them in the microscope, you cannot use gram stain. When you have to appreciate Salmonella typhi, you would look, you just take the organism from the blood or from the culture that you have grown, you stain them by gram stain, they will appear gram negative. These organisms, okay, will not stain by gram stain. That much you must remember. And all of them are transmitted by arthropod vectors. That means either by tick, by mites, by flea, or by louse. If these arthropod vectors are not there, the chain of transmission of these diseases is broken. Okay? And we can categorize, there are so many diseases and you'll get thoroughly confused when I show you the next few slides. Okay, but these important things that you must remember is that, okay, they are fastidious, they are obligate intracellular pathogens, they do not stain by gram stain, they are pleomorphic, they do not have any specific shape. All of them are transmitted by arthropod vectors. Please remember, either by a tick, by a mite, by a flea, or by a louse. Okay, and we can roughly or categorize them into two groups. The Rickettsia bacteria which cause typhus, the typhus group which cause endemic typhus, epidemic typhus, and the bacteria which cause the spotted fever group. we call them, where rashes are there. Okay, rashes are there in both. So we can roughly divide them in the typhus group and the spotted fever group. And don't get you will get very confused when you see all this, because some of them are transmitted by lice, some by tick. But I'll try to give you some tips how to remember them. Okay. So if you make smears from infected tissues, the Rickettsiae will appear as pleomorphic gram-negative cocobacilli, but this is not really true. You will never be able to appreciate them. You will have to use special stains, okay? They are non-motile and non-capsulated. They stain bluish purple with Giemsa and Castaneda stains. These are the stains that we appreciate. I wrote here that they may be gram-variable or gram-negative, but the fact remains that you will not really appreciate. You have to be very, very experienced to see that. So it is best for you to remember that it is best to stain them by Giemsa or Castaneda. They cannot grow in cell-free media. So for obvious reasons, if you try to grow them in your blood agar, your chocolate agar, they will not grow. Because they are strict intracellular pathogens, you will, unlike Salmonella, though it was a facultative intracellular. Okay, Salmonella, though it multiplies within the cell, it can grow outside the cell. Okay, please remember this. But these organisms, you cannot grow them in a blood agar or chocolate agar. They need a cell to grow. Okay, someone must have taught you the diagnosis of viral infections. Even viruses cannot grow outside the cell. So you use special kind of culture. They are called tissue culture. Okay, to grow them, you have to use special culture media which contains cells. You have to infect those cells with these bacteria. Then only you will appreciate their growth. Okay, and the growth generally occurs in the cytoplasm of the cell. Whichever cell you use, the growth will occur in the cytoplasm of the cell. These are some common features. That's why I have told them together. Okay, arthropod-borne, strict intracellular pathogens. They do not stain properly with gram stain. You have to use special stains like Giemsa stains. Okay, and they're all transmitted through the help of an arthropod. Okay, this is how they may look. Okay, Gimenez stain of tissue cultures. So these are the special tissue culture cells. That means you have to maintain cell lines, and then you infect these cell lines with the samples collected from these patients. Okay, so this is, so you can see it is infected. This is a cell line which they have stained, and it is containing these bacteria. If you have to classify rickettsial bacteria, okay, they belong to two main groups. You have the Rickettsia which contains the bacteria Rickettsia and the bacteria Orentia. In Orentia you have one specific bacteria called Orentia shushugomashi, which causes your famous scrub typhus. Scrub typhus is very, very common in India. It's very common in Meghalaya also, especially in the West Khasi Hills. Then you have Ricketsia species, which causes your epidemic typhus, endemic typhus. Okay. Then we have another family belonging to this Rickettsia. It is called Anaplasmatidae. This contains the Ehrlichia, which is amongst these, Ehrlichia is the commonest bacteria causing human infections. Okay. So in the beginning itself, you would see most of the names are tongue twisting, difficult to remember. Okay, but nevertheless, you cannot escape, because these diseases, especially the ones which are prevalent in India, you must know. Okay. Prior to, like I said, taxonomy keeps changing, classification keeps changing. Okay, when I was a student, apart from all these, I had to study other two bacteria also in this group, Coxiella and Bartonella. But for your information, I'm sure you're reading the latest textbooks or the latest edition. These former members, these bacteria like Coxiella burnetii and Bartonella henselae, okay, they are removed now from this group. Why? They have been removed. But when I was a student like you, I would study Bartonella henselae and Coxiella under Ricketsia only. Okay. Now these two have been removed because Coxiella burnetii, which causes Q fever, okay, it is not arthropod borne, and it is transmitted by inhalational mode. Okay. So it is not caused by arthropod. That is the reason why Coxiella, you will be studying Coxiella separately as miscellaneous bacteria. It causes a disease called Q fever. Okay. Bartonella henselae, okay, it causes a disease called Bartonellosis. Okay, this is infection commonly seen in AIDS patient. It is not an obligate intracellular parasite, and it can grow easily on cell-free media. For these reasons, these two organisms have been removed from this classification. Okay. Now, because you cannot grow these I'm telling you general points, because you cannot grow and identify them using cell-free media, they have to be grown in something more special, isn't it? So you can grow these organisms in the yolk sac of a developing chick embryo. Chick embryo has been used for cultivating or culture or isolation of mainly viruses. Okay. Again, I hope that when you were taught laboratory diagnosis of viruses, you must have been shown these chick embryo, where you can grow the virus either in the amniotic sac or the amniotic fluid or the yolk sac or the chorantic electron membrane of the chick. So if you have to grow Rickettsia bacteria in an embryonated chick, okay, in an embryonated egg, hen's egg, okay, you will have to target the yolk sac because these organisms, these Rickettsia will multiply only within the yolk sac. We do not put the sample inside the amniotic fluid or amniotic cavity. Okay, you will have to put in the yolk sac because in the yolk sac, these bacteria will multiply. Then you will harvest it and stain it to see whether these bacteria are there or not and identify them. Okay, apart from the embryonated hen's egg or chick embryo, they will also grow on cell-specific cell lines. Okay, you try to remember, it may not be possible, but they will grow on specific cell lines, and they also grow in the embryonated egg, yolk sac of the egg, hen's egg. Okay, for primary culture, that means if you culture for the first time, okay, it is very difficult to grow on tissue cultures. That means these cell lines. Okay, sometimes apart from the yolk sac of the embryonated egg, you can grow these organisms in the, you can pass them into the peritoneum of the guinea pigs or mice. Okay, you can take the sample from the patient who's suffering from rickettsia and inject it into the peritoneum of the guinea pig or mice and then see for the changes there. That is very good, especially if you are going to culture for the first time. So coming to the pathogenesis, okay, pathogenesis also is similar for most of them, so I will be dealing them together. It is transmitted mainly by arthropod vectors. Okay, if it is transmitted by a tick or by a mite, then it's usually the mite or the tick will bite the human being. Okay, if it is louse or flea borne, then auto-inoculation can occur by rubbing. Okay, if the louse is there, suppose there's a body louse and the patient scratches, okay, because he feels some itching. So there can be, he rubs the area. So rubbing or scratching of the abraded skin or mucosa contaminated by insect feces seen in epidemic and endemic typhus. Okay, so this is very, very important. Okay, you must understand if it is by tick or mite, it usually by biting. If louse and flea, sometimes when you rub the, you try to kill the louse or you rub it because of irritation, the insect feces can be self-inoculated on the auto-inoculated in the abraded skin. Sometimes, even though we say that it is arthropod borne, sometimes these infections can also be spread through aerosols by inhaling dried louse or flea feces. Okay, though it's rare, this can also occur. Okay, regardless of which species of rickettsia it is, most of them, okay, have the similar pathogenesis. Transmission is also similar by arthropods, and the pathogenesis, what they cause in the body also will be similar. Most of them, they will cause, okay, all of them, in fact, they will cause a vasculitis kind of picture. What is vasculitis? Inflammation of the blood vessel wall. And this is caused by the invasion and multiplication of the organism in the endothelial and smooth muscle cells of the blood vessels. Okay, so this, please remember, in general, when these bacteria get access into the blood, okay, they will cause inflammation of the blood, there will be vasculitis, okay, and this is mainly because the bacteria has invaded and multiplied in the endothelial and smooth muscles of the, muscle cells of the blood vessels. This is a generalized, I'm just saying pathogenesis is usually, it's common, I'm saying they will cause this kind of a picture. And how will the patient present? He will present with thrombosis, occlusion and necrosis of the blood vessels. There will be thrombocytopenia, there will be hemorrhage, okay? There will be a large, massive capillary leakage into the interstitial spaces, which will result in edema, hypotension, hypovolemia, and ultimately adult respiratory distress syndrome. Okay, some of them will present with encephalitis. We have seen patients presenting with encephalitis, myocarditis. Okay, that means, okay, CNS is also involved, the heart, myocarditis is also involved. There will be nephritis. These are the common clinical consequences or complication of a untreated case of rickettsial disease. Now, like in the beginning, I have said you can divide them roughly into typhus group and you can divide it into the spotted group. Okay. In the typhus group, we have diseases, okay, like epidemic typhus, late complication is called Brill-Zinsser disease or endemic typhus, and of course we have scrub typhus. Scrub typhus is common in India, in many parts of India, and that also I'll show you in the next slide. They are all put together as a typhus group, okay? Because they cause diseases which are like epidemic typhus, endemic typhus, scrub typhus is there. So Rickettsia prowazekii, the bacteria which causes epidemic typhus is Rickettsia prowazekii, and you can remember that this is transmitted by louse. So when I was a student like you, I was taught that if it's an epidemic, it is lousy. You cannot do anything. You cannot run away. Okay. So epidemic typhus is transmitted by louse. So if epidemic is there, like for example, now we are having this COVID-19 situation. It is epidemic only. It's everywhere. So I cannot flee and run here or there because everywhere it is in the whole country. Okay. So we say that if it's epidemic, it's lousy. We just used to remember like that. So you can't run anyway. But if it's endemic, endemic means it is located only in one place. You can fly, you can flee to another place. You can remember it like that. Endemic typhus is transmitted by a flea. Endemic is located only to one geographical area. Okay, so if you want to remember which is the arthropod, you can run away from there. You can fly, flee. That's how we used to remember. Okay, and then the organism which causes an epidemic typhus is Rickettsia prowazaki, and the one which causes endemic typhus, which is transmitted by flea, is Rickettsia typhi. Okay, and we have another one which I didn't include in the first table, scrub typhus. Scrub typhus is caused by Orientia susu-gamushi. Okay, Orientia susu-gamushi. Okay, please remember, scrub typhus is caused by a. Okay, there are, remember in Rickettsia group there are two. One is Rickettsia, that is caused Rickettsia prowazaki and Rickettsia typhi, and the other one is Orientia group, and in that Orientia we have Orientia susu-gamushi, which causes scrub typhus. Okay, so these are the diseases which is caused, and rash is seen in all of them. Okay, so it's very, I'm telling you, it's very, very difficult to differentiate between one and another type of rickettsial disease because they present very commonly in the same way. Okay, so rickettsia in rash is seen in both endemic and epidemic typhus as well as in scrub typhus, but it is more in the typhus, the epidemic and the endemic typhus. In epidemic typhus, you will see all over the body except the palms and soles. Here you will see mainly in the trunk. Eschar is a lesion where the mites, as it bites, okay, it will bite to enter, no? The larvae of the mites, the sugars we call it, it will bite. So that is the region I'll show you. That is called an eschar. You will not see an eschar in typhus group, that is, in epidemic and endemic typhus, but you will definitely see an eschar in a scrub typhus. But the only problem is, it is not present, you will not be able to locate this eschar in all patients. Okay, lymph node is involved in scrub typhus, lymph node is affected, but it's not affected in endemic and epidemic typhus. Okay, this is about a serological test which we will study later. Okay, so I don't know whether you will be able to recollect all of them, but I will just try to tell you that epidemic typhus is caused by prowazaki, okay, transmitted by body louse, okay, and usually these louse will get the infection by feeding on a blood meal. That means, okay, blood means the louse will bite a person who is already infected and he will shed the bacteria in the feces. Okay, this is how the infection will go on. Okay, auto-inoculation can occur because the person will rub or scratch, and the skin will get abraded, and that's how the contaminated feces containing the rickettsial bacteria will get inside the next person. Okay, inhalation also can occur, but it is very rare. Okay, so you will have vague symptoms, headache, myalgia, eye discharge, rashes. Okay, then you will get complications like pneumonia, mental confusion, myocarditis, and so on. So this epidemic typhus is very, very common in areas where there is a high louse population, in refugee camps, prisons, overcrowded communities. Okay, and you must remember, sometimes you may be asked, what is Brill-Zinsser disease? This is recrudescent illness occurring years after acute. That means incomplete clearing of this bacteria from the blood. Recrudescent illness occurring years after acute epidemic typhus. Okay, so Brill-Zinsser disease is nothing but epidemic typhus only, which can occur, it's kind of a relapse, okay, which can occur very much later. Okay, this is how the rash of the epidemic typhus will look, but it is very non-specific, I can tell you. Very, very non-specific. Many rashes also appear like this. Endemic typhus, okay, this is flea-borne. It is much milder than epidemic. Okay, it is caused by Rickettsia typhi, which we used to call Mussuri, is a causative agent. Okay, forget the name of the flea because you will not remember. Okay, Rickettsia will multiply in the gut of the flea, and Same like in the case of epidemic, the flea will shed it in the feces. The flea itself is unaffected but remains infectious for the rest of their life. They'll keep shedding the rickettsia in their feces, but they themselves will not get affected. Okay, and human infection is a dead end. Okay, and man-to-man transmission does not occur. So you require a flea for the continuation of this particular disease. In endemic typhus, remember, endemic typhus is transmitted by flea. The clinical presentation is less severe compared to epidemic typhus. Okay. Presents with fever, headache, myalgia, anorexia, and rash. Okay, the rash involves the tongue mainly. Then you have another one, Indian tick typhus. Okay, the main ones is epidemic typhus. Then you have the endemic typhus, and you have the Indian tick typhus. Okay, this is transmitted by a tick. Then this is similar to the Rocky Mountain spotted fever, which is there in the next group. This should have come in the spotted fever group, I'm sorry. The eschar will be there, that is the site where the tick has bitten. Okay, at the site of the tick bite in 50% of cases. This is there in India. In many places, you will not, in India it is widespread, it's everywhere. Okay, this is the eschar of the Indian tick typhus. It looks something like this, the area where the tick has. Okay, so if you become a clinician later, and you have these vague symptoms, you have rashes, try to locate if there's an eschar, because this is very classical and very clinching of the diagnosis. Try to see if there's an eschar. Sometimes you might have the eschar, in exposed areas, or sometimes, at the thigh or any area you can have. So you must examine your patient thoroughly to see this eschar. Okay, apart from that Indian tick typhus, we have other tick typhus which are not very common in India, so we will not go into it. Okay, then coming to scrub typhus, which belongs to the scrub group, typhus group, sorry, we have this this is very important, okay, scrub typhus, or it is caused by this organism called Orentia shushugumashi. The meaning of this is that susugum is dangerous, mushi is by an insect or mite. It is found only in certain areas where the climate is suitable for the organism to survive and where there's a lot of scrub vegetation. Okay, so it is very common in places where you have the scrub vegetation. These mites, they inhabit the sharply demarcated areas in the soil where the microecosystem is favorable. They are called mite islands. Humans are infected while passing through these mite islands. They are bitten by not the mite as such, they are bitten by the larva of the mite. They are called shigas. Okay, so when you are bitten is very, I can tell you that we have cases, lots of cases here in NEIGRIMS also. And in particular in Meghalaya and West Khasi Hills, scrub typhus is common because of the scrub vegetation and the suitable environment for these mites to grow. Okay, and we have the characteristic eschar over the site of the mite bite. So it's very, very important. And this eschar, like I said, will not be only on the exposed areas. Okay, sometimes you might have in the upper thigh, sometimes you might have in the upper arm, okay, in the breast, anywhere. Because these shigas can move and bite. So you must see this. Okay, and scrub typhus, there's a classical triad of an eschar. So if you see that eschar, it will be very, very classical. Regional lymphadenopathy will be there and rash will be there. Remember that in epidemic and endemic typhus, you will not get lymphadenopathy, but here you will get lymphadenopathy. And you will also get rash in around 40 to 50% of cases. Apart from these, this is a very classical finding. Apart from this, you will have vague symptoms, non-specific, like fever, headache, which is there in enteric fever also, myalgia is there in every viral infection, cough, and gastrointestinal symptoms. So, finding these will not help you. But if you get this clinically, okay, if you see these clinically, you might clinch your diagnosis, okay? Complications can occur from encephalitis to pneumonia to vascular injury, anything, okay? We will not go into the next one. Okay, this is what is the eschar, you can see. Okay, this is in the breast, you can see this eschar here. Okay, so you try to look for these, okay? They'll present to you with very vague symptoms. So what I said, the classical triad would be the eschar, the lymphadenopathy. Okay, that you have to see, and the rash if it's present. But unfortunately, these things are not present in all the patients. Okay, and for the survival of this bacteria, Orentia shushugumashi, you have to have these mites. Okay, you have to have secondary scrub vegetations. Okay, and the season has to be wet. Meghalaya is a very wet region. Okay, because the mites will lay the eggs which will develop into the larva. It's a larva which will bite, the chiggers we call. So it has to be, the season has to be wet for the mites to lay the eggs to develop into larva. The mites have to be present in that region. Okay, the season has to be wet for them to lay the eggs. There has to be vegetation or forest and the presence of these mammals. So a combination of all this will enable the survival of these organisms. And this is very, very common not only in Meghalaya but in many parts of our country, many parts of India. Okay, then we come to the next group, that is the spotted fever group. Okay, and I think I have time, no? Yeah. So in the spotted fever group, we have many. Okay, like I have mentioned, sorry, the Indian tick typhus I've already told before. Okay, it should have come after this. We have the Rocky Mountain spotted fever. All of them in this are transmitted by ticks, except for rickettsial pox, which is transmitted by mites. Okay, so all this in the Rocky Mountain spotted fever, they are transmitted by tick, except for this, which is transmitted by mite. Okay, and like I said in the beginning, it will be very difficult for you to remember the species, like Rickettsia rickettsii transmits Rocky Mountain spotted fever. Rickettsia conuri transmits Indian tick typhus. You know, if you remember, it's good, but I don't know if all of you can remember. It's going to be very, very difficult. Okay, now here also the presentation, if you see, majority of them present with rash. Okay, rickettsial pox, this is not there in India, so you can forget about this. This rickettsial pox, the rashes are vesicular. Like you've seen in chicken pox, you must have suffered, no? Chicken pox, or you must have seen cases. They will be vesicular. These will be macules. They will just be discoloration, the rash will be just a discoloration in the skin. It will be flat. Here they will be vesicular. Okay, Eshkar here also can be seen, like in scrub typhus, Eshkar can be seen in the spotted fever group. In Indian tick typhus also you can see, rickettsial pox you can see. But in Rocky Mountain spot fever, it's very difficult to get a Eshkar. Okay, lymph nodes can be enlarged in all this, especially in rickettsial pox. You can see lymphadenopathy. Okay, we will not talk about the wheel felix now. Okay, so Rocky Mountain spotted fever, this presents as a very severe disease. Okay, it's transmitted by ticks. Okay, these are the names of the ticks. Okay, you will just have to forget about it now. So transmission is by tick bite. Tick serves as vector as well as reservoir. Okay, it is the most fatal of all the rickettsial diseases. When you compare to endemic typhus, epidemic typhus, scrub typhus, Rocky Mountain spotted fever is the worst. Okay, it is the outcome is very bad. Fatality is very high. Okay, incubation period is 4 to 14 days. This is the, you can see this is a rash. Okay, patient presents with headache, rash, and frequent myalgia and anorexia. There will be rashes on the extremities, wrists, and ankles, and trunk also. The complications appear very late, but remember that all of them will have complications. But here, the fatality rate is very high. They will present with vascular damage. Like I said, all these are common to all the rickettsial diseases: increased permeability, edema, hemorrhage, DIC, disseminated intravascular coagulation, interstitial pneumonitis, CNS involvement in the form of encephalitis, then cardiac involvement, myocarditis, and even renal failure. Okay, so you must remember Rocky Mountain spotted fever is transmitted by ticks. Okay, it is the most severe or fatal amongst all the rickettsial diseases. Okay, then rickettsial pox. This is also coming in the spotted fever group, and the tick typhus also comes in the spotted group. Okay, the Indian tick typhus. This is the mildest of all the rickettsial disease. You have Rocky Mountain spotted fever, which is the most severe or most fatal. This is the mildest. Okay, it is self-limited. You don't even have to give any medication. Non-fatal. Sorry for the spelling mistake. This is vesicular exanthem. The rashes are vesicle-like. Okay, it resembles chickenpox. I've told you. That's why it's also called vesicular or varicella form rickettsioses, because it resembles chickenpox. Okay. It is transmitted by mite, unlike the other diseases in the Rocky Mountain spotted fever group, which are transmitted by ticks. Okay, the name of the Ricketsia is Ricketsia acari. Okay, this is how it may look. Now coming to laboratory diagnosis. Okay, in general, antibody detection is a mainstay of diagnosis, and the famous serological test looking for the antibodies against this Ricketsia is called the Wheel Felix test. Unfortunately, this Wheel Felix test also, like your Vidal test, is not very specific, because the antigens we use, okay, here we are looking for rickettsial antibodies, but the antigens we use are shared antigens. That means antigens which can also react to rickettsial bodies, antigens which can also react to protease antibodies. Okay, protease is another bacteria. So this test is not specific, because it contains, that's why it's called a heterophile aglutination test, because it is using antigens, okay, using antigens which are not specific to rickettsia. These antigens are there from proteus, but they can bind to the antibodies against rickettsia as well as to the antibodies against proteus infection, okay. And the test should be done after 5 to 7 days of onset of fever, okay, and the titer of 1:80 or more is possible infection. Okay, so wheal Felix test, you must remember, it is done for rickettsial diseases, not for all of them, okay, but for these diseases, epidemic typhus, endemic typhus, or the spotted fever group. OX19 antigen, OX2 antigen, and OXK antigen. You will see that in epidemic typhus, you will have reaction for OX19 and OX2, but not for OXK. For endemic typhus, you can see reaction or agglutination, only for OX19. Okay. For tick typhus, you will see reaction, tick-borne spotted fever group, you will see agglutination both. This is a agglutination test. Okay. So these what I'm writing plus is agglutination. So tick-borne spotted fever group will show agglutination. That means antibodies against OX19 if it's present and against OX2 antigen is present, you will see agglutination. Scrub typhus will have agglutination only against the OXK antigen. That means if you collect blood from a patient suspected of scrub typhus and you perform this wheal Felix reaction, you will see agglutination only against the OXK antigen. So this is a very, again I will say non-specific, because here we are using antigens which are not from these antigens are derived from proteus. So there will be cross reaction. If a person is having proteus infection also, he might have reaction to this. Okay, and they are not very, very specific. So we have, fortunately today we have specific antibody detection tests, though they are very difficult to perform in the laboratory. Even here in NEIGRIMS, we don't have this indirect immunofluorescence assay, but this is a gold standard test. Okay, where we look for specific antibodies to rickettsia and where we use specific antigens. Okay, the titer of more than 64 is considered as significant, and the sensitivity and specificity of this IFA is almost 94 to 100%. Okay, sensitivity is 94 to 100% and specificity is 100%. Then apart from this indirect immunofluorescence assay, which is the gold standard, we also have specific IgM ELISA for the diagnosis of rickettsial diseases. Okay, then we can do other tests like indirect immunoperoxidase assay and rapid test that is based on immunochromatography. Okay, but these are not recommended. Okay, you either go for wheal Felix or for this gold standard or for ELISA. These tests are not recommended. Okay, other methods of diagnosis, of course, is histological examination of a cutaneous biopsy sample from a rash. Okay, but this is also not commonly used. Or we can grow the organism. We can take the blood of the patient where the rickettsia is multiplying, and we can use tissue culture cell lines, or we can, now this is also obsolete, we can take an embryonated egg and grow it in the yolk sac, or we can inoculate the blood sample of the suspected rickettsial patient into a guinea pig. Problem of growing them is that these are highly infectious. Okay, we have had in the first slide I have showed you that Howard Taylor, okay, and one Provosek, they died of the disease. So we cannot afford to do culture unless we have a very good biosafety level 3 facility. Okay, unless that means we cannot just do culture the way we did for enteric fever or for UTI, for urine or anything, because the chances of the person who's doing the culture, the chances of him getting infected is very high. So we have to have a biosafety level 3 facility if we are planning to diagnose rickettsial diseases using culture facilities. Okay, this is very, very important. We have had many people dying of rickettsial diseases in the laboratory. Okay, so unless this facility is there where we ensure the safety of the laboratory personnel, we should not venture into culture. We can diagnose mainly on serological tests, whether it's wheal Felix or whether it's indirect fluorescence assay, but we should not go into this unless this facility is there in the laboratory. Okay, this is another one. Okay, you might be asked what is this Neal-Musser reaction. Here we take the specimen from the patient and we inoculate it intraperitoneally into the male guinea pigs. Okay. So if there is scrotal necrosis, then we presume that the patient is having infection due to Rickettsia rickettsii. If the guinea pig ends up only having fever without any testicular inflammation, then it is due to Provoseki. Okay. And these other rickettsial also, typhi, konori, and akari, their fever, the guinea pig will have fever and positive tunica reaction, that is testicular inflammation. Okay. Apart from all this, in this day and era, we can also do molecular tests where we look for the specific DNA of the specific rickettsial. Okay, we can do, suppose we are diagnosing scrub typhus, we can look for the specific DNA of the Orinchia shishugomushi. Okay. And these are the samples that you can take for the molecular test. Okay. Now the best part about this disease, these rickettsial diseases, is that all of them can be treated by ordinary simple antibiotics like doxycycline. Okay. This is very, very important. It is a drug of choice. Doxycycline is, and there's no resistance reported as yet, not much, to doxycycline. Or we can give simple drugs. These are drugs, antibiotics, which are been used for a long time, but resistance has not been reported, at least in rickettsia. So we can give doxycycline, okay, or chloramphenicol. And because of that, many, I tell you, sometimes, they give it presumptively only, presuming that it's rickettsial disease, they can start off with doxycycline because this can save the patient's life. Okay, and prevention, of course, you must know that no vaccine is available. Okay, but the only way is to control the vector and the reservoirs, that is the rodents and the animals. Now, I think I will just go, 2-3 slides are there. Okay, just to show you, I think it's overdose only, but apart, then you have the Rickettsiae family, then you have the next one. This also comes under Rickettsia. We have the Anaplastaceae, okay, family. Here you have Ehrlichia, you have Anaplasma, you have Neuricketsia. Okay, they cause different diseases. Okay, Ehrlichia schaffensis causes human monocytic ehrlichiosis. This will cause Ehrlichia ewingi will cause human granulocytic ehrlichiosis. Okay, this Anaplasma group will cause human granulocytic anaplasmosis. Neuricketsia. Okay, at least this slide you can try. It causes human lymphocytic ehrlichiosis. Okay, so you have a Rickettsiae group and you have a Anaplastaceae group. In the Rickettsiae group, you have Rickettsia and Orentia. Okay, and in Orentia, you had only that Orentia shishugomushi, which causes scrub typhus. Here you have 4 bacteria. Ehrlichiosis is responsible for 3 types of human diseases. Okay, Ehrlichia senetsu, which causes glandular fever, Ehrlichia schaffensis, which causes human monocytic, and Ehrlichia equi, which causes human granulocytic ehrlichiosis. You really have to mark these things because it's difficult for you to remember. Okay, this glandular fever due to Ehrlichia is reported from Japan. Okay, it is endemic in Japan. Okay, there is no arthropod vector here. It's mainly caused by, you must remember this, ingestion of fish carrying infected flukes. Okay, leading to human infection. So this is mainly in Japan. It is endemic also there. Then you have the human monocytic ehrlichiosis. Okay, this is transmitted by ticks. Okay, it is caused by Ehrlichia schaffensis. Okay, patient presents with multi-system involvement. There may be leukopenia, thrombocytopenia, and elevated liver enzymes, and the fatality rate is very high. Okay, very rarely you will get short notes on these also. For your information, scrub typhus is important. The other rickettsial, spotted fever, the tick typhus, the typhus group, they are important. This you will not get, but in your MCQ, okay, MCQ you may get, because nowadays in your question paper, you have already finished, no? You are in the new curriculum. You may get MCQs, okay, where, for example, they will say glandular fever of ehrlichiosis is transmitted by arthropod or ingestion of fish. So you remember these. So that's why I have given only 3-4 points. And this is endemic in Japan. Okay. Then you have the next one, human granulocytic ehrlichiosis. Here also, okay, this one, see, this one is by ticks, this also by tick. Okay. It is transmitted by tick. It can cause by these species of Ehrlichia. This also presents with leukocytopenia and thrombocytopenia. Okay, so that's it. I think you have to go back to your textbooks. You have to read. Okay, Rickettsiae will not come as a long question. It will come only as short notes here and there, or as MCQ based questions where they will write rocky spotted fever. Mounted fever is transmitted by dash. Ticks, fleas, mouse, lice, whatever it is. Okay, it will come like that. Or Wheat-Felix test can come as a short note. It's a very important serological test for diagnosis of Rickettsiae. Okay, you will not get an entirely long question or applied question in Rickets here. You will get only short notes or 2-3 marks, but you have to read it. And it is very difficult to remember because there are so many bacteria in one group. So I will, encourage you to go back today, when you finish your classes, and just go through the book once. Okay, when you come back, when we have offline classes, maybe we can discuss it again. Okay, so thank you.